All right, our next speaker is Kristen McConnell. She is from Miami Cancer Institute. She's a board-certified senior proton physicist at MCI, which is part of the Baptist Health of South Florida network, and her research is focused on proton dynamic arc therapy, biological modeling of particle therapy, and improving efficiency and standardization in the proton therapy physics workflows, as well as treatment delivery. So welcome, Kristen.
All right, well, thank you, Melissa. Today I'm going to talk about proton dynamic arc and specifically some research that we've been doing with breast and chest wall irradiation. So I figured maybe let's start out just to make sure everybody knows how protons deliver in the intensity modulated proton therapy or IMPT world, which is not dynamic arc, right? Spots are scanned over the target volume and we change energy to go to like the next layer essentially. So we always deliver distal to proximal, at least right now, and you spot scan one energy layer and then you move forward, spot scanning the next. In this case, right, dose modulation is possible. It's kind of similar to the step and shoot IMRT world. So what does the dynamic arc world look like? This is an arc-based proton delivery. Now it's not being treated yet, but it's something that is coming on the scene hopefully next year, particularly in the IBA one-room centers. Now at MCI we have the 3-room Proteus Plus, so there are some differences. We're expecting that maybe in the next 2 years from IBA. But the idea, right, is that the proton gantry will move during the entire treatment. So right now we treat with static fields, but in the future we're going to have our gantry moving, and at each gantry angle it will deliver one energy layer and move on to the next. That way the gantry is constantly in motion and you have these multiple control points all around the target. So you're unlocking a different solution space, right? You potentially have more degrees of freedom that now allow you to change the way you're delivering protons. So more of like a VMAT, right? What can this enable? Well, you may have improved target conformality. We may see improved OAR sparing. We may see different LET distributions, and I'm going to talk about that today. You might see higher integral dose, right? That may be less important clinically, but it is something to consider. And then you could possibly see unlocked treatment efficiency as well. So what did our study look at? We specifically pulled 4 cohorts of breast and chest wall patients that we find is kind of the diverse scenarios we treat in our clinic. The first one being expander cases. These are fairly common. We get a lot of these. Sometimes we have trouble treating them in protons. One of the major things, right, is that we can't treat through the port. At least we don't at our center. So we have a beam arrangement that has some geometric limitations. So we have to consider if these patients, each patient is a good candidate or not. So we wanted to see how that would be impacted with dynamic arc. Permanent implants and no reconstruction chest walls, as well as bilateral breast. Those are sometimes hard to treat given geometric limitations of our machine, so we end up with different beam arrangements that sometimes add time to the treatment. So in this study, we're looking at 40 patients, 10 in each cohort, and comparing dynamic arc versus the conventional plan that we treated with. There's 2 options in RayStation that you can plan arc therapy with. The first is discrete arc. The second is dynamic arc. I've kind of already given it away which one we're going to use, dynamic arc, but just so you know, there is 2 available ways. The first one, discrete arc, allows you to have many gantry angles in the same fashion, but at each gantry angle, you have multiple energy layers. So you're sort of delivering like a standard SOBP plan at each gantry angle. In the dynamic arc, like I said, you only have one energy layer per gantry angle. That way your arc will just continue around the treatment area, right? So we're using dynamic arc to plan these cases. And what are the beam arrangements that we're comparing against? So for the IMPT, we have fairly typical beam arrangements in our clinic. I can tell you, probably within 10 degrees what it's going to be, just by looking at it, because we have standardization across across these cohorts. So for expander cases, we always treat with 3 fields, and it is largely a hybrid plan where some of it is SFO, some of it is MFO. The MFO portion is, of course, around the expander port. And then for bilateral disease, we will usually have 3 fields. So we'll treat, if we can, with 2 anterior obliques and an AP. Sometimes we have to kick the couch. If the patients are wider than our treatment field, we can take advantage of it on the 90-degree kick. So that adds a little bit of complexity, right? A little bit of time to do the kick and the imaging. And then we also sometimes have to treat 2 ISOs on bilateral breast, so 4 fields. And then for our normal no reconstruction chest walls or just permanent implants, we'll just have 2 fields. So those are relatively quick. And then, of course, comparing against your dynamic arcs, so that's what they would look like in this case. How did we plan these? So for the arcs, for cohort 1 and 4, we did 160 degrees retraced dynamic arc, so one way and coming back. That may not be necessary. I've seen some research out there, and I've been working on nasopharynx where we're not doing retracing and we're still getting good plans. So that's something just to note as we go through this today, that these are retraced, so when you see how many spots we have in layers, know that we went there and back. And then for cohorts 2 and 3, we just did 150 degrees, so just dropped it by 10. We didn't feel like we needed as much space on those. And then for the optimization, we used a cohort-specific optimization set. So up front, I worked with dosimetry to find what we felt was the best for that cohort, and then we ran it the same on each patient in the cohort. Something that was exciting, at least for me, was the GUDs seem to work really well for the OARs in dynamic arc. And I was used to using those in photons before, so I know when I started just IMPT planning, we were having a little trouble using them, but for the arc, they worked really well. And we didn't have to make that many extra structures. We just straight up used the structures. So we were pretty happy with that. Of course, for the IMPT plans, these were the beam arrangements I showed you. And what we shared across everything was, of course, we used Monte Carlo for everything. These were optimized and evaluated robustly with a 5mm setup uncertainty and 3.5% range uncertainty. All of our cases had a 7.5 centimeter range shifter, and we met all the coverage and robustness requirements. And we also used the LETD tool inside of RayStation. So what did we take out of this? So all the dose on screen, right, is shown in RBE 1.1 dose. So of course we extracted that per OAR and CTV. We pulled out the LETD. So looking voxel-wise, I'm going to show you some plots of that. And then we did some statistical testing comparing IMPT versus dynamic arc. So starting off with the CTV coverage, this is the subtraction of the 2. So anything midline, it's 0. There's no difference essentially. And then off to the right is dynamic arc showing better coverage of the CTVs, and off to the left is IMPT showing better coverage. What you notice is there is a fair amount stacked onto the right side where dynamic arc was showing better. The asterisks represent statistically significant. So in cohort 1, the blue, you'll notice that most of the CTVs actually showed statistical improvement with dynamic arc, and those are the expander cases, and I'll show you why specifically that looked that way. And it may have robust implications, so we'll go into that. And you'll notice that there was one, the permanent implant actually showed better on IMPT, and the chest wall, no reconstruction cases, they all kind of trended better toward IMPT as well. The next question, right, is what did the OARs do? And you kind of see a clustering around 0, that we didn't see tremendous improvement with a lot of them, and we actually saw some of them get worse with IMPT. So we saw the esophagus mean value get worse, we saw the thyroid mean get worse, but we did see the LAD for the ipsilateral expander case improve. So this is kind of, I wouldn't say there was like blinding, like, wow, this is incredibly improved, but it is, they are kind of similar, right? And then specifically looking at the lung, we were looking You can see that the permanent implants, we did see improvements, at least in the V5 and V20 of the ipsilateral lung. And there was also quite a bit of variation between cases. Now, this is my favorite part, looking at the LET distributions inside the CTV. So this is just a plot. We pulled out all voxels, so all individual voxel dose and LETD pairs, and graphed them in a heat map to see how they're changing. And what you see in the IMPT plan, this is specifically for one of the expander cases. So inside our high dose CTV, what you notice, right, is in the mid-range dose in the 20 to 30 gray range, and the high LETD, that it exists on the IMPT plan, but it is largely gone in the DynamicArc plan. And you also notice the red circle at the bottom that the high dose, low LET that isn't in the IMPT has now been added to the DynamicArc plan. So what does it mean? We need to evaluate it with some RBE models to help us answer what is the impact of this, but we know it changes, and I think that's interesting, especially, I'm not going to present this with OARs here today, but like I said, I'm working on a nasopharynx study where the underlying LETD maps do change and the dose changes. So how is that meaningful, I guess? That could have implications for toxicity in different ways. And then we looked at I just wanted to show you how the distribution sort of changed for LETD. So this is the median LETD across the cohort, pairwise cases, so the lines mapped case to case. And you'll notice that the distribution tightened up for the most part for DynamicArc. So we did see kind of a squishing of the distribution and a lowering overall of the median. Still in the same range, basically, of 2.2 keV per micron to 3.2. So not changing it tremendously, but definitely making it more consistent. And I'll note that we didn't do any LET optimization on these plans. We just let it deliver how it will, and this was the result of that. So, moving forward, we could look at LETD optimization, and we could change these underlying distributions in any way that we want, right? Now, this is kind of the interesting one. Beyond all the cool physics and dosimetry of it, what does this look like at the machine? Because we have to be able to deliver it, right? So we did some time estimates and some time savings estimates. And again, remember, this is we do have a 30 by 40 field, so not like the IBA one-room centers. They have a smaller field, so these would not be necessarily the time estimates for those centers. And it might change with the layers. And also remember, we did retrace these arcs. But nonetheless, looking at DynamicArc versus IMPT, we saw, on average, more spots on the DynamicArc plans. We also saw more layers. However, we wanted to look at just beam time at first. So what we did to estimate beam time was I pulled probably 30 breast cases across all of our cohorts that we've treated. So pulled them out of the IBA system to see what the time of delivery was, and then referenced their spots, got a time per spot, like an average time per spot across our clinic, and then multiplied it plus our layer switch time is 0.8 seconds. So multiplying that, adding it up, and getting an estimated total beam on time. What you notice is the DynamicArc beam on times are a little bit higher, right, than the IMPT ones. But the additional thing we have to consider is how do we set these cases up? And anyone that works at a proton center, at least ours, right, we go in the room between every field. So we have to go open the door, we go in, we move the gantry, and we research the room and leave. So we estimate that's about 3 minutes to do that. And so we're doing that every time that we're going to change a field. Now, if there's a couch kick, like I mentioned on some of the bilateral cases, we do a kick. We will go in, do all that. We'll also move the couch. We'll also take a KV set to make sure the patient's in the right spot. And we estimate that's about 6 minutes. So these total times on IMPT, I'm adding in the going in the room, changing it, and needing to take images in the case of the bilateral set. So that's why the beam on times are the same for DynamicArc in total. And if you compare those total times looking at cohort 1, which is the expander cases, we observed a 4.5-minute time savings with ARC. Now, for the other 2 cases, we actually observed that it took longer. And then for the bilateral, we estimated there could be about a minute savings. Again, this depends on how you plan the cases. So this probably needs its own optimization. How do you set your spacing between your gantry angles? How many gantry angles do you need? How many layers are you going to need? Again, it depends on your field size as well. So there's lots of things that could change this answer, but we just wanted to present what we saw, at least our initial set. So what are we most excited right now? Now that we've seen all this data, is there something that we're really excited for breasts? And I think the answer is yes. It's the expanders. You saw that there was some improvement statistically with coverage. Why is that? And this is why. So if you see here, you're looking at the DynamicArc plan on the right, and you see there's a lot of red. Red is our prescription dose, and you see that it's very tight up against the expander port. So we are expecting a hole of dose because we're not treating through that port. And you can see on our IMPT plan that that hole exists, but we're not able to get prescription right up against the back of the port. Now, that's saline, right? That breast expander is made of saline. There's not target in there necessarily. However, these cases, when you go to set them up, they generally set up okay, but we do absolutely have cases that we get called to the machine for where there's a pitch, a roll, something that's changing the beam path, especially around this port, and the robustness comes into question. So we always evaluate it up front, but there are things that change at treatment. And so we're thinking if the dose looks like the DynamicArc case, instead of the IMPT case, that robustness may be better on these cases. And so that's going to be one of the studies that we do next, is to evaluate with real patient QACTs, how does this hold up, and does it hold up any different than IMPT? So that's one place that we are excited about this. And beyond just the robustness aspect of these breast expander cases, there is some geometric considerations. So I told you that sometimes we can't treat all these patients, and we're kind of informed by this rule. It holds fairly steady in our clinic that if there is at least 1.5 cm from back of the port to the boundary, that we are usually able to achieve coverage, but if it's any less, we really struggle. And this bilateral case was one that we definitely struggled on to get coverage, and I'll show you the comparison because we replanned it using DynamicArc. So on the right-hand side, you see our IMPT plan, and you see on the patient's left that we do not even have 45 gray at the back of the chest wall. But you see with the ARC that we do have 45 gray. We almost got full 50.4 coverage. So I think that cases where the filling of the expander isn't good enough, in a sense, right, for geometry, and it's not possible to bring these patients into plastic surgery and get them filled, that we unlock potentially more patients that we can treat. So I'm kind of excited about this. I think this is going to be one of the first places for breast that we would consider implementing ARC. And then just to kind of conclude what we've seen, for the expanders, we did see statistically improved coverage with that potential robustness improvement. We did see the LAD D03C improve, but we did see a loss in esophagus and thyroid mean values. Potentially that's due to our planning template, right? Maybe if we changed it, we would see improvements there as well. We did see decreased lung sparing, and we saw that mild time improvement. So again, I think expanders is where we would probably start. Looking at the permanent implants and the no reconstruction cases, not only did they take longer to treat, slightly, we still saw the loss in esophagus and thyroid mean. We did see a little bit of improvement in coverage. So it's not like we couldn't treat these, but again, I think we saw the most bang for your buck in expanders for now. And then for bilateral disease, we saw statistically improved coverage. Again, we saw the loss in the esophagus mean value and improvements in lung sparing with a little bit of time improvement as well. So bilateral would definitely be an option that we could treat. I think you could treat any of these, but again, we'd probably start with the expanders. All right, thank you. So if you have any questions.
We probably have time for one question.
Thanks, Christine. My question is, have you considered about the motion, respiratory motion for the ARC plan, especially for breast?
What motion? Like patient motion?
Yeah, patient. Not patient motion. Respiratory motion. Breathing motion.
Oh, breathing motion. Okay, sorry. We haven't looked at that yet. We do have a study underway right now for looking at like retrospective RTOG 1308 cases to see how those dynamic ARC plans would hold up. One of my colleagues is working on that, but I'm not sure. We don't have any data for you to show you yet.
And Dr. McConnell, just a quick question. This is all in silico. You guys, are you going to be implementing an early version of DynamicArc at the center? Do you know physically? I mean, the machine's
So
not-
our goal for Miami Cancer Institute is to definitely bring ARC online. I know LCI, my colleagues are in the crowd out there. Their goal also, they'll probably get it earlier than us with the one room center, but their goal is to also implement it.
Very good, thank you.